There's always new literature being published on new studies, new evidence that need to be taken into account. And every 5 years, the international group, of which the American Heart Association is one member council, works for several years to update the guidelines using new evidence in a very careful and rigorous process of evidence evaluation. And the member councils develop an international consensus on science, and then each of the groups returns to its home and writes its own guidelines. So American Heart guidelines were just published last month. One thing that's important to know is that this time around we did not review the entire set of guidelines. So we did a focused update. So some things are no change, some things are updated, some things are brand new. In basic life support, what was updated was the rate of chest compressions for victims of cardiac arrest. And the old recommendation, which was still usable, was at least 100 per minute, but it's now been boundaried by an upper limit of 120 per minute because of studies showing that once you get much beyond that, if you're compressing too quickly, you start compromising depth of compressions, and that trade-off is not good for the victim. What happens is that you don't press as deeply because you're going so fast, and it compromises the effectiveness of the CPR. That is true for adults in the studies. The same guideline has been adopted for children for whom there really isn't any evidence, but there's no reason not to make it the same. We hope that it will make CPR quality better because that is the most important factor for a victim of cardiac arrest, that they get early, high-quality CPR. And by having a better sense of the rate guidelines, it should get even a little better than it is now. So we're going through the update process now for instructors. As you can imagine, the process of disseminating the information, creating new training materials is one that takes some planning and logistics. But we did an instructor update for advanced life support, pediatric, and basic life support instructors last Thursday and Friday. And we had over 1,000 people attend. So that was a start. Those are really our frontline training network folks who will now go back and start training using the new materials. And every instructor in the country will go through an update, which can be done actually online through our instructor network. The pushback is oftentimes because people don't necessarily know a lot about the process. We do get the, oh, I just learned it this way, you're changing it again. And in those cases, it's important to remind people that we're not changing it just because, we're changing it because there's new science, and we want to make sure that we're recommending the very best way to help people. Other changes include the addition of naloxone, Narcan, to the guidelines for people who might be victims of opioid overdose, really recognizing that that's a public health problem. It's a reality in our country. So that's been incorporated for people who are not breathing. The AHA really doesn't have a formal role in it. They're acknowledging that it's one of the causes of arrest, and in the spirit of wanting to make sure that we have, again, the most effective guidelines possible, this has been incorporated. There's been a lot of advocacy on the part of groups who work with this problem in this population. But the AHA does not recommend any particular stocking or carrying of naloxone. It's local protocols. It really varies by state and even by municipality as to whether their providers or lay people, public safety people, can use Narcan. I think in general, Narcan good. If you give too much Narcan to someone who is a chronic user of narcotics, you can certainly cause problems. It can make them sick by making them go into acute withdrawal. But for someone who's overdosed, the dose of Narcan that's being recommended is pretty small and is hopefully just enough to reverse the breathing problems without causing any harm. The removal of one medication that was used for cardiac arrest, and so instead of a choice of two, it's limited to only one, which is epinephrine, and vasopressin was removed. The other thing in the advanced care that was really clarified this time around was what we call targeted temperature management. So the management of a patient who's been resuscitated from cardiac arrest, has a pulse, and now is in the hospital in the intensive care unit. And one of the things we know is that managing their temperature seems to be an important part of their recovery from that whole event. There's been numerous studies, and dating back now over 12 years, looking at different ranges, durations, and protocols for targeted temperature management. And there's some really important new evidence that came out suggesting that perhaps it was not so much the depth of hypothermia, but more so keeping someone below the fever range. That was the intervention. So those recommendations have been updated to acknowledge that there's probably a range of temperatures over which it is okay, but shouldn't allow the patient to get a fever. Well, the targeted temperature management, which used to be called induced hypothermia, and the concept has sort of morphed, is already been in place in most centers in North America. It's part of the guidelines, Get With the Guidelines programs. It's part of the bundle of care for post-cardiac arrest. And so I don't know that there's much in the way of significant change other than that temperature range that is now recommended. It's a big challenge. I mean, it really does depend on, for healthcare providers, it depends on our training network. For a lot of the lay public, it depends on the training network. But we will use any means possible. Events like this discussion, media events, apps for your phone, PSAs, there's just numerous ways. And we have a whole communications department that works on that sort of thing to try to make sure the message gets out.